I now request Dr. Sandipan Dhar to please come on stage and present the final talk of the day on hypopigmented lesions, sans vitiligo, in pediatric age group.
I shall be talking on hypopigmented conditions without discussing anything on vitiligo, but I'm sure that some of our pediatrician colleagues would like to ask some questions, and we have got a very dynamic and generous moderator, Dr. Shamanta Barua. I'm sure that a couple of questions on vitiligo he will definitely allow you to ask, and we as panelists will love to answer. So I shall go a little bit fast because, I was told that many of you have got flights to catch, soon. So what are the hypopigmented conditions by and large? Because any child coming with a hypopigmented lesion or the mother bringing a child to you, over the face, as Abhijit just now, showed to you, causes a lot of concern in the parent's mind. So basically, if we try to divide or classify them, they're either genodermatosis or inflammatory diseases, diseases of infective etiology, then nutritional disease, and drug-induced. So in the genodermatosis, I am not going to read out the list. You can see what are the different conditions. As I said, I shall go a little bit fast. So this is albinism, autosomal recessive in inheritance, and there are different types of albinism, but most important thing, single most important thing is that use of sunscreen throughout the day, number of times. Most important thing that you must, make the parents aware about that. And their hair color is also, as you can see, diluted. So yesterday I mentioned about this entity, piebaldism. You can see the piebaldism patch usually appears on the forehead like this. However, I said yesterday, if you remember correctly, that piebaldism can affect any part of the body. So here there is a piebald family which came to us in our Institute of Child Health. The two siblings, has got piebaldism. Even the mother has also, on examination, we found that mother has also got piebaldism, which somebody thought as, vitiligo for a long time. So this was only by temporal correlation, by back calculation, you can say. So Waardenburg syndrome is when you see this depigmented condition along with this type of, cartwheel type of appearance in the retina. So, and most important thing is that whenever you diagnose a case of Waardenburg syndrome, you have to refer this child to a pediatric internist or pediatric neurologist because they manifest with a lot of neurological abnormalities. And of course, ophthalmologist. Asleep macule of tuberous sclerosis, yesterday it was discussed at length. Couple of photographs I'll show. See, the mother has got classical adenoma sebaceum and the child has asleep macule. So what can be more convincing to diagnose, epiloia in such cases, right? And you advise a CT brain or MRI brain. The lens of a sepate macule, yesterday it was discussed. But interestingly, like vitiligo, in asleep macule also you can see perifollicular pigmentation at times. So don't be, scared of making a diagnosis of asleep macule because you have to search for other features of tuberous sclerosis. See, multiple asleep macule. Many of these, children with tuberous sclerosis, apart from having asleep macule, they have hypopigmented macules over the face, right? So these are the type of hypopigmented macules, which is well described in literature. If you are, very lucky, I must say, and search for it, because this is found in only in 20% cases of tuberous sclerosis. You may find this periungual fibroma, which is known as Cohen's tumor. Coming to another entity, nevus depigmentosus, whenever the mother sees the baby, gets scared that this is vitiligo or not, most important advice to the mother or the parents is that you just be observant whether the child is going to develop more such lesions, and if the child develops, then come to me. Otherwise, this will increase in size in proportion to the growth of the child. Because usually what happens, the mother says, doctor, this is increasing in size. अरे बच्चा तो बढ़ रहा है ना, इतना छोटा था, अभी इतना बड़ा हो गया. So it is proportionate to the growth of the child. That is most important advice you can give. However, if you see number of lesions are coming up, then please report to me. So you may have a nevus depigmentosus in a zoosteriform distribution. Nevus depigmentosus border is usually crenated or irregular, unlike vitiligo, which is very clearly defined, as it is described, oval shaped border. Nevus depigmentosus, I have an advantage of convincing the parents of nevus depigmentosus, because I myself have a nevus depigmentosus on my right elbow. So when they are not getting convinced, I show my elbow, look at this. This is what I have. So your child has also got the same thing. Hypomelanosis of Ito is, streaks like hypopigmentation, unilateral. Importance of diagnosing it is again musculoskeletal, ocular, and neurological abnormalities. So you have to take the advice of your pediatric internist, for our dermatologist colleague I am saying, and we must refer according to the symptoms or the complaints of the mother. Like this, hypomelanosis of Ito. So this is just the negative picture of incontinentia pigmenti. See, such nice photograph of hypomelanosis of Ito you won't find in standard Western textbooks also. So coming to disease of infective etiology, pityriasis versicolor, yesterday I mentioned, this is, hypopigmented lesions, scaly lesions, and if you try to scratch with the fingernail, you will see some hipped up scales, and this is well described in the standard textbooks, known as fingernail sign. You should not have any difficulty in diagnosing pityriasis versicolor. And treatment is very rewarding, unlike many other conditions where the treatment is not that rewarding. Post-collagen dermal leishmaniasis presents this like this hypopigmentation, the cause of which is not yet known. Well, leprosy can present with hypopigmented patches. In a child, it may be very ill-defined patch known as indeterminate leprosy, or borderline tubercular leprosy can present with hypopigmented patch with satellite lesions. Then hypopigmentation over the face may be because usually it is atopic diathesis known as pityriasis alba. However, we have been seeing number of cases of polymorphous light eruption nowadays, presenting as hypopigmentation, not only over the face but also over the forearm, as you can see. They have a little bit appearance, what we dermatologists say is a lichenoid appearance, right? We go strictly by the morphology. Okay? This is polymorphous light eruption, right? You see, parents get very much anxious about it actually. And the moment you explain to them that, look, your child is playing, going out to play without using sunscreen, this is one of the indications where you should use sunscreen routinely in these children. And they are playing in the school, and because of ultraviolet light, they are developing it. There is an entity known as pityriasis lichenoides chronica, which I have been seeing increasingly. I am sure my colleagues are also being seeing increasingly because we have become quite aware about it. Any hypopigmented conditions all over the body, search for red points like this, red points like this. These are vasculitis. This is a small vessel vasculitis actually, right? And it has to be treated with oral steroid for at least 4 to 6 weeks along with methotrexate. Methotrexate you might have to give for 6-7 months or year or even more than 1 year, right? Because it doesn't get controlled very fast and it is not vitiligo. And you have to tell that, and they respond, their hypopigmentation respond nicely to narrowband ultraviolet B1 therapy. Post-inflammatory hypopigmentation in skin of color, so infantile seborrheic dermatitis presents mostly as post-inflammatory hypopigmentation. Some of the inflammatory conditions, pityriasis alba I have showed. This is another condition, inflammatory condition. This is known as lichen striatus. A linear band, parents will bring the child with a linear band without much itching, much symptom. Child is playful, only the parents are jumping out of tension, right? So here the counseling is very important. I am telling you one particular molecule which is very useful, topical tacrolimus. Initial topical steroid for 2 to 3 weeks, followed by tacrolimus for 6 to 7 months, and this responds nicely. LSA or lichen sclerosus atrophicans earlier used to be thought that this is a disease of the adults. No. There are a large number of series in children. LSA is fairly common in children. I see quite often LSA. I diagnose LSA like this. Same like adult women in small children. They present with figure of 8 pattern of lichen sclerosus atrophicans and ask 2 important histories. Ask the mother whether the child complains of burning sensation, particularly during maturation, right? Before you examine for the gritty sensation of the lesion. Then you will differentiate, you will be able to differentiate it with vitiligo. That is a very important differentiating point. Topical steroid abuse again. And I am very lucky that I am standing in front of Kaushik, Dr. Kaushik Lahiri, the torchbearer of topical steroid anti-abuse movement. Otherwise he will kill me when I go down. So topical steroid anti-abuse movement in IADVL. So avoid use of topical steroid. This ulceration was not there. There was some erythematous papule, and all this ulceration and hypopigmented halo was created because of use of potent steroid like clobetasol propionate for months together. So that's it. These are all from my book, which I have earlier mentioned to you. Thank you very much for your patient hearing.